Good morning, everybody. Good morning, Christine.
Good morning.
I want to welcome everybody and thank you for attending. And I'm very excited because I'm going to have a cup of coffee with one of my all-time favorite people, Christine. And, the way I've been looking at this is that it's kind of nostalgic. I was thinking about the last 50 years. That's pretty nostalgic. And sort of the way I began the work and then everything that's influenced me along the way. And it's like, Christine, you've been there like every single step along the way, every year. It's kind of wonderful. And you are so prolific that you tend to take everything that's coming out and pulling it together in a cohesive kind of way and summarizing it. And, it just, I greatly admire you. And I like your mind and the way it works. And what I like most about you, actually, I like two things about you. One is that you're a clinician. And so a lot of people write or they do research, but every day you're in the field working with clients and you're able to apply what you're learning, which gives you a different kind of perspective than many people in the field. And of course, the second thing I like about you is this, that the person you are. I mean, when I first met you, I immediately loved you. And, it's hard to explain what that is, but it's a connection that you have with another person because they've got a heart, as big as this room and you can feel it. And of course, that's what makes you a great clinician, is that you're, that wonderful ability to form a secure attachment. So anyway, I was thinking about an introduction for you, and I can give all your credentials, and I can talk about where you are in the American Psychological Association, the Committee on Trauma, all that you've done to help the field progress itself. But, most of all, what I admire about you is who you are as a human being.
Well, thank you very much. I appreciate it. It has been quite a journey, and we have been colleagues and friends for 40 plus years at this point, and we have followed each other's trajectories in many, many ways. And I could say the same thing about you in terms of having a very big heart and having a lot of integrity and really trying to develop this work as we go along. We've done it differently, but we've both done it. So I look forward to that part of the conversation today.
Well, let's start. I mean, I guess the burning question that I have, and I read each of your books many times, and you cover it in every one of your books, but I want to discuss it verbally, which is a lot of people say they do trauma therapy, and they say it oftentimes, because they've taken a course in EMDR, or they have the client talk about what happened to them in depth. And I've often asked myself, what are the criteria that one needs to satisfy to be able to say they do trauma therapy? And what is trauma therapy? And what are the kind of credentials that a person needs to have in order to be able to do competent trauma therapy?
Oh boy, you get me up on my soapbox on that
one.
Oh
boy.
Oh boy, this has been a soapbox for a long time. Excuse me. As you know, those of us who started in trauma work back 40 or 45 years ago had a very, very steep learning curve, whether you were working with combat PTSD or whether you were working with the post-traumatic consequences of child abuse at the time or in adults. And many of us can say that we made every mistake in the book because we didn't have any training back then. There was very little that we could go by in terms of literature or in terms of help. And we didn't even have a diagnosis at the time. And so that's developed. But in order to do competent trauma work, I believe people need to have very directed training in what is trauma, what happens to traumatized people, how to approach them, how to interact with them, and also how to modulate the interactions or titrate them so you're not overwhelming the person or you're not underwhelming the person and going nowhere. And that's been sort of the big, both of those, the big issues in the field right now. And, you know, you can get certification in any number of techniques, but that doesn't mean that you know how to do psychotherapy. And it also doesn't mean that you know how to do psychotherapy with the traumatized, because most of those trainings, and I've taken a couple of them, as you have, don't emphasize what it's like to work directly with a traumatized person and how carefully you need to assess their readiness for a particular technique. You also know that there's a controversy in the field about whether treatment needs to be sequenced and applied in a hierarchical kind of way, with many of us who treat the complex consequences of child abuse saying that it does need to be sequenced and we need to resource people before they go forward and do the trauma work. But also that we need to be doing attachment and developmentally related treatment that is helping with not just the PTSD symptoms, and that many of the evidence-based trauma formulations or trauma treatments at this point are directed towards the reduction of trauma symptoms, which is great. But for complex trauma folks of the sort that we treat, that's not all that they're dealing with. And they need to have a more extended and more in-depth and more reflection of them kind of psychotherapy that many programs don't teach these days, which is really unfortunate. Over the last number of years, I have been involved in the American Psychological Association efforts at putting together a list of competencies. It's now part of APA policy, starting at the beginner level and going up to the expert level, that at various levels that the clinician should have a variety of competencies in terms of knowledge, in terms of skills, and in terms of attitudes towards working with the traumatized. Because we also know that traumatized individuals are very often misunderstood for what happened to them. And they're often stigmatized and judged even by those of us who are supposed to be taking care of them. So all the more reason for us to learn, and to learn how to manage our own reactions and our own responses. And this is where attachment theory comes in also, that we need to be able to be what's called secure attachment or earn secure attachment, so that when we work with our clients, we are not getting overwhelmed or triggered or underwhelmed ourselves, and that we're staying pretty steady state and pretty reliable and consistent in the interaction that we have with our client, with the understanding that the relationship is the foundation of the work upon which we put the different strategies that we choose and the different sequence. So that's a long answer, but that's how far I've gotten with it so far.
Well, let me add a couple elements. I mean, I feel greatly fortunate. You and I opened up a dissociative disorders unit trauma program inpatient at a similar time. Mm-hmm. And honestly, I'm so grateful that I did it that way, because I learned about dissociative disorder, and it was a different lens that a lot of people get when there comes with trauma is a fragmentation of the personality, mm-hmm. and a disorder of the self system. Mm-hmm. And so what I've become aware of, particularly because I deal with addicts, is that the real underlying problem is there is not an integrated sense of self. And so along the way, that one of the things that influenced me greatly was I was trained by one of Mary Main's staff on the adult attachment interview. And when I got that training, Dan Brown and I did that together with Lori. It was breathtaking because you began to understand, what Mary Main called a cohesive, coherent, collaborative narrative. And in that, you begin to get the structure of the developing self. And so, the idea of doing trauma work is that a person can begin to integrate a sense of self. And so we have people who come in who have very little self, and they're primarily driven by their addiction or by their false self. And so integrating the basic psychoanalytic principles, psychodynamic principles of object relations, was critical to this. And when we ran the eating disorder clinic, what we discovered was that you could do a certain amount of work inpatient, and then the person needed to go out in the world and practice a lot of the stuff that they were learning. And the next 2 or 3 years, it came together. And when that happened, there was a much more cohesive sense of self, and the person's addiction then began to move back. So the result was that a whole different formulation of understanding addiction, which is that, relapse is part of recovery, and that you don't look at an acute intervention as necessarily the cure, but it's a way of removing some of the blocks to the development of the individual to become who they're, genetically programmed to become. And so, what I used to say to Bessel is that everyone keeps talking about how effective the treatment for PTSD is, as if that's the treatment. But resolving PTSD is a step in the treatment, but it's not the treatment.
Right.
And so, I think people get confused by that, particularly when they're using empirical approaches, because they're looking at measurement devices of, did the depression remit? Did the anxiety remit? Did the PTSD remit? All those things being necessary, but rarely sufficient. So we have never done a really good job of defining sort of the bigger picture.
I totally agree with you. Well, I totally agree with you. And you know that I chaired the APA clinical practice guidelines that were published in 2017. And I subsequently wrote a critique of that process because it did exactly what you said. It reviewed only those studies that were randomized clinical trials of what are now called trauma-focused therapies that have been found to be very effective in terms of the remission of PTSD symptoms. For the most part, some of them remit depression and anxiety, as you're saying, but it's not a whole person treatment. And especially for those who have interpersonal traumatization and complex trauma that has really impacted their sense of self and resulted in, as you're saying, self-fragmentation, self-alienation, self-hatred. They need more than just to have their symptoms remitted. Also, for some of them, they may not be ready to do that work right away. And that's what you're saying also. So it's good for them to have their PTSD symptoms under some control or remitted, but that's not the whole picture for many of the individuals that we work with. So I espouse that going forward and building and looking at a recovery process and also a relapse model and a stages of change model that is going to occur over a period of time. Not the same for everybody, but that's another thing that we've come to learn, that there are different treatment trajectories. There's different degrees of healing. It means different things to different people. There are different resources. There are different cultural healing rituals that we need to do a better job of incorporating. So it's, Lori Perlman and I wrote an article years ago, and we developed a mantra: complex trauma, complex reactions, complex treatment. We're dealing with lots of different things that, another thing that happens if somebody doesn't have training, as often is the case, and they start treating some of these folks who have multi-problems, they have no idea where to start. The therapist doesn't. And so having a sequence and having a formulation that really addresses what you're saying, that it's a process over time and it comes together over time, is really helpful. And that's what I've tried to write about in the last few books with Julian Ford, to try to articulate all these different issues that come up and that need attention.
So let me put you on the spot again. If you had to pick one person that's influenced your psychotherapy practice more than anybody else, who would you pick?
Oh boy, that does put me on the spot. I actually have to say 3 people. Judy Herman, my colleague and business partner, Joan Turkis, and Jim Chu, as well as Bessel. So I have 4 people. But you've been highly influential too, because you've come at it from a different perspective, and it's always been very stimulating to have the discussions we've had about our own trajectories and our own paths.
Thank you.
Including developing a dissociative disorder unit at a time when that was something really new. We didn't know, again, necessarily what we didn't know, and we learned it by doing. And I also want to give a shout out to all the people that have developed dissociative disorder treatment, that have published on that have helped us learn about these patients. And you know, what's been so exciting to me as well is how all of these different strands have become integrated in our understanding. The attachment research, the disorganized attachment, which is highly dissociative attachment, that renders somebody incoherent and renders them not quite fragmented all the way to DID. You know, I've really appreciated the way all of this has come together and is still coming together.
Absolutely. Yeah. The only person I would add to your list, which has really knocked me off my feet, has been Peter Fonagy.
Mm-hmm.
His influence in terms of his training with Mary Main and understanding that and integrating with self-psychology,
Right.
reflective function has been really important in looking at this idea of how you facilitate the developing self in the self system.
Mm-hmm.
So let's go back to the beginning. In the early days, I mean, what I did was I went to the library and I studied World War I, and I looked at the abreaction literature from World War I, and I was trying to understand how to treat rape, and there literally was practically nothing written on the topic that I could find,
Mm-hmm.
although you dug up tons of stuff. I went to the library, I couldn't find as much. And so the person in those days that really, I think, influenced you and me would be Mardi Horwitz. And he talked about abreaction and catharsis and the stress response cycle. And I loved his conceptualization, and I still do. I don't know how many people have actually read his work or even influenced by it. But in some ways, it confused the field because abreaction suggested that there had to be a component of re-experiencing of the trauma in a safe way. And catharsis meant in some ways that there was a stress response cycle and that there needed to be some sort of energy release around the body holding the toxicity of the trauma.
Mm-hmm.
And the following that, of course, it got a bad name for a variety of reasons. How did that influence you?
Oh, that influenced me a lot. But I went in a different direction again. I did start in the area of rape, and I did find some of the early books that came out at that time that were very helpful. The earliest research, and I'm not remembering the researcher's name, I'm sorry. But, you know, I shifted my focus to adult survivors of incest early on, because the Rape Crisis Center that I co-founded, we started to get calls from those individuals who were still being molested or raped at home, in the home. And when I did my dissertation, the challenge was I didn't think there was any literature at all. Turned out there was a ton of literature, but it was mostly by social workers and by psychiatrists, not psychologists. And so I began by really looking at the after effects of the long-term consequences, which Judy Herman did also in her book, Father-Daughter Rape. And as we looked at that, we began to apply what we learned from the rape literature to treating incest or other kinds of child abuse, which is not a good one-to-one fit by any means, because it was treating an acute trauma. Unfortunately, though, we learned that many individuals who are later raped, it's a re-victimization or a re-traumatization, and they've already been molested or raped. So we learned pretty quickly that these were individuals that had more complicated histories. So we had to begin to develop treatments that attended to those various issues, which we did. So that's how I came about it and did my library research.
Well, in those days, there was a strong emphasis on not allowing borderline patients to talk about rape.
Right.
When we opened our unit, we couldn't hire a psychiatrist because the psychiatrist said, well, with borderline patients will regress and become psychotic if you start talking about the trauma. And I said, you people are nuts. How can you have people coming in who've been traumatized telling them not to talk about the trauma? It seems like absolutely crazy. And then to dictate that from the psychiatric standpoint. And so what we needed to do was to demonstrate that talking about trauma may help people get better, not worse. And there wasn't a lot of empirical research to show that.
Right. I agree with you.
I feel like that's always been a dilemma.
Yes. And the other person that was highly influential at the time, and since then, is John Briere, because John early on put an illustration together that showed the after effects of child abuse were consistent with borderline personality disorder. Now, we now recognize there are some differences between the two, but that most individuals with borderline personality have complex trauma formulations. And in fact, now some of the most effective treatments are those that are longer term and that are of the type that Peter Fonagy and his colleagues put together. And they're multi-component and they address multiple things. But this is where attitudes come in, because if a clinician approaches somebody that comes in symptomatic or characteristic of what we know of borderline personality, they often get labeled immedately in a very negative way. They often get told that they'll never be able to get better, which is not true. And they're further stigmatized, and they incorporate it into their negative self-esteem. One of my favorite clients used to say to me, "But I am borderline. How can you say that I'm not borderline?" And I used to say, I don't use that term, but you are complex trauma. You were traumatized. And over time, we came to an agreement over that. But she had been so maligned, and so she had incorporated that as who she was, rather than, again, what had happened to her and how she had come about with the adaptations or the defenses that she had developed. So it took a long time to unravel that and to put the pieces back together in a different way. But I think many of us in the mental health field really have had to take a very strong look at ourselves and how we've treated these individuals and how they still get treated. I still get clients who come to me and tell me how they were mistreated or maligned by the very people they went to for help. And it creates another level of trauma. And of course, and I'm going to put a plug in here, Mark. Of course, the very worst scenario is when a client is sexually abused by a therapist in the course of therapy, which is, a grossly unethical thing, but a grossly traumatizing thing. And my latest book is exactly on that. And what we did in this book is to focus on the client victim and all of the prices that he or she, and there are male victims as well as female victims, that he or she pay when they are used or abused by a psychotherapist. And often these are individuals that have been diagnosed as borderline personality. They're often seen as seductive, so it makes it their fault rather than put the blame and responsibility where it belongs on the therapist. Another long answer,
Well,
sorry.
it brings me to my, no, it's fine. I think it brings me to my pet peeve, which is, each of us have had a different lens of going into this field. And my lens has been through the sex addiction field and love addiction. And so the thing that influenced me early on was Bessel's article on reenactment. The body keeps the score. A lot of people saw that in his recent book, but he wrote that back in 1970s. And it was an incredible article in a psychiatric journal. And it was exactly what I was seeing, which was the burning question was, a person would come in who was incested, and then they would have 6 or 7 or 8 rapes after that. And the question, always was, well, of course, why is it that a person is susceptible to these repetitions? And so Bessel, in his formulation of Desnos, said that pathognomonic of the syndrome is a susceptibility to re-victimization.
Right.
And so it's, I think, a burning question for the client and for the field about why these reenactments occur and how to stop them. And so, I've really focused on that a good bit. And because, a lot of the people I still see, they get into these destructive relationships and they find themselves hurt again and again and again in intimate relationships. And so even if they've done good trauma work on the PTSD, they still seem to be highly susceptible to repetition and reenactments and so on.
Right.
What are your thoughts about that?
Well, it's interesting that you put it that way, because repetition and reenactment are not exactly symptoms, are they? They're more a process issue that occurs, and it's a process issue that has to do with relationships with other people. And it's part of the new complex trauma diagnosis of disorders of self-organization. And so there are lots of things that are missing in what many of our clients and survivors learned. And they've learned many backward messages about human relationships. And that material relates to their self-esteem and their sense of self, but it also is very intertwined and very compounded. And so it is important for us to attend to both of those, because until we attend to that, they may continue to have these ways of relating to people that make them highly susceptible or highly vulnerable to being re-victimized. I love it when a client comes in and says, my picker for partners is broken, because I don't, all I end up with is abusive people. I don't know how to have a healthy relationship. And, they have that, when they can begin to acknowledge that and know that, then, there's an opening to do the work. Again, that's what makes abuse by a therapist so egregious. I call it professional incest, because it takes the very vulnerability of the individual and uses it against them in a way that re-traumatizes them. So we have to be exquisitely careful about that. And I know you've written about it, Mark, and in this new book, we've written about it also. And, we've really tried to impress on the field, and will continue to do so, that we have a sacred responsibility not to act out these misunderstandings of relationships with our clients. We have to teach them about healthy boundary relationships.
All right, now, next step, which is, when I was at Castlewood, my previous treatment center, the first 100 patients that came in, we gave the adult attachment interview and scored it. And what we found was that 98% of the clients had disorganized attachment.
Mm-hmm.
And so my hypothesis was that our principal focus was on eating disorder. But I thought that the clients who were going to get better were the ones if we treated the disorganized attachment effectively rather than the eating disorder. Because what we did with the eating disorder was necessary but not sufficient. And so my basic belief was that we have to learn how to treat disorganized attachment more effectively.
Mm-hmm.
Dan Brown, in his book on attachment disorders in adulthood, wrote an encyclopedia of the literature that existed at the time. It was just breathtaking. And I've always loved Dan's mind anyway.
Mm-hmm.
But I'm curious about what you think is the treatment for disorganized attachment.
Oh, that's an easy question too. Well, thank you.
Breakfast with Mark.
Right. Well, some of the starting points are the therapist, him or herself. I think we've got to provide a context that is a safe haven and that provides the possibility of secure attachment, and that the relationship is both the container, but also a model and also a catalyst for a lot of information and a lot of material that comes in via relationships and via behaviors on the part of the client. But I think that we have to provide that foundation, and that to do that, we need to have our own secure attachment that allows us to be there and be in context with the client. And that's a starting point. And then I think that we need to begin to notice with clients what they do, how they do it, their inconsistencies, their paradoxes. These are all ways that they learned in their background to deal with people who were creating havoc in their lives and creating gross inconsistencies. And that we have to show them, I think, that there's another path and ways to begin to relate differently to people. We also need to understand as therapists, and I know I'm taking the therapist side here and speaking more to that, but I think we need to understand that relationships for these folks are not safe. And even if we provide the context of safety, it's going to take a long time for this to develop and this recognition to develop on the part of the clients. And so we need to be patient. We need to understand where they're coming from. We need to try and not take it personally. When, one week you're loved to high heaven and the next week you're hated. And there's no in between, or you have a client who comes in and expects that you are going to sexually abuse them, and in fact might be provocative to just get it over with. We have to stay very steady and know that it's not about us. Those are often reenactment dynamics that are based on disorganized attachment. And we have to hold steady state to our own boundaries and to working with the clients from a position of knowledge and a position of kindness, and help them to understand why they're doing what they're doing, because they may not have any conscious awareness of it. So trust is something that is earned on the part of the therapist, and it is something that should be given over time by the individual, which might be a whole new concept for them. So those are
you're talking about the relationship with the therapist as critical, and that's certainly component one.
Mm-hmm.
I think we're on the border of a paradigm shift, and the book that really touched me more than any recently was Schwartz's book, The Development of a Person. And the reason that excites me is that he provides really rich data, which looks at adult psychopathology as the end result of a developmental process. And in that process, you see that the early attachment environment is actually the cause of a lot of adult psychopathology. Not that they're not genetic and brain influences, but they're obviously touched by this early development. And so we now have all this neurological data and the work that's been done in developmental neurobiology of beginning to look at developmental psychopathology, which I think is the most exciting advance of our field. And what I get out of that is that the primary deficit with disorganized attachment is in metacognition, and that metacognition is the mind of self and the mind of others. And the real problem with the person who has a disorder of self is that in their own mind, they have contradictory beliefs about self and other, and then they're not really good at reading other people. And so what happens is that they get into destructive relationships because they really don't have the ability to be able to make those judgments about others. And so a lot of what I've been doing with disorganized attachment is work around metacognition. And I thought that, that Bateman and some of the work with Fonagy on that was really instructive, and being able to, in a very structured kind of way, begin to teach people how to be able to be better at accurately assessing self and other.
Yes.
The other thing is that they tend to idealize their family, and being able to neutralize some of the loyalty to the family system.
Right. Well, and that's where, I think another major contribution has been the betrayal trauma theory, which helps us, from yet another angle to understand that, the attachment is there even to abusive others, and certainly disorganized attachment teaches us that as well. But when these individuals come up against the issue that they've been used or abused by trusted other people, whoever that person is, and the closer in, the more betrayal, that's an enormous crisis very often, but it may be enormously freeing for them too, and help them to understand. But what I really like about that theory that Jennifer Fried put together is, and what her findings were empirically, is that it involves betrayal blindness, is that someone who has been groomed and betrayed by an intimate or a series of intimates doesn't have the structure to be able to understand that. And they become blind to betrayal. And so one of the things that we need to do is to be helping them in a metacognitive way to begin to understand those kinds of things about themselves and what they're expecting, and about the reality of situations out there. So I'm just repeating what you're saying from a different perspective. But this is where I think the field has developed. There's all these different aspects that have come together. What you're saying about developmental psychopathology, I like to call it developmental traumatology, is really looking at what are the developmental trajectories and how can it go wrong, and especially with disorganized attachment. And these are individuals who have learned that very often they're not responded to until somebody wants something, and then they're exploited for what the other person wants. Or they may have an abuser who, at some points they have, a pretty healthy relationship with them, but then on the other end, it can be highly abusive or highly non-responsive. And so they're dealing with contradictory information all the time and trying to put it together for themselves. So, those are the kinds of things we have to help with in psychotherapy later on.
Getting to the nuts and bolts, probably the one thing that's influenced me more contemporary in how I work was Kathy Steele out of Van der Hart's work and structural dissociation.
Mm-hmm.
And the way it's influenced me is that typically when I'm working with somebody, I start with the symptom. And the symptom is a window to me. And I'm just listening for the symptoms. So if the person comes in and says, I relapsed, or I'm in a destructive relationship, or I'm in a lot of pain and depressed about X, that to me is a weird place to start. And if I follow that, it'll lead me to whatever happened to them in some way. And so
I like to think of it as communication. Yeah. Mm-hmm.
Go ahead.
No, go ahead. I was just saying, you said a window, and I like to think of symptoms as communication.
Right. So in the old days, maybe when I was younger, I would think, the person is relapsing, or the person is, what am I going to do to help them through this pain? But now I think of sort of the symptom as a gift, because it tells me what how the past is manifesting itself in the present. And so I fluidly just follow it, and it'll lead me right to where I need to be able to go. And of course, whether I'm using EMDR or their internal family systems, or I'm doing cognitive reprocessing therapy, or any of the structured formats for dealing with trauma, they all now have sort of melted together. It's fascinating. Like I took a recent course in EMDR. I'd done the original with 25 years ago. And, it's funny because it incorporates all the great advances in the field. And I'm not sure they even know when they're teaching it, where a lot of the stuff is coming from. But all that work that you're doing around being able to help people be able to do the work piece by piece like that is really an orientation of noticing in a dissociative way that the manifestation of the symptom is the door into the trauma.
Mm-hmm. Yeah, I would very, very much agree with that. And that is the starting point.
And they've built in resourcing in a much more structured way. And it's beautiful because, the biggest fear in the field was that the work could be re-victimizing because there wasn't adequate resourcing and grounding and containment. Mm-hmm. And so adding some of these real structured ways of resourcing really allow you to be able to titrate the process as well as the cognitive interweave. And you get the beauty of the competency of the therapist and their unique creative abilities with the actual empirical work of doing the structured work. And I doubt if any two people do trauma work the same way, but yet there is some similarity if you've been trained in one of those formats.
Right. And I think we get at some of the same issues, but maybe approach them very differently. But you said something really important just then, which is, we need to maintain a sense of humility also about we can do harm in doing this work, which is why it's so important. Like, I'm just impressed, for example, that you said you went back and did some more training with EMDR. That's the kind of thing that needs to happen so you can stay in a contemporary mode and know what's going on to be able to do this work. Several of us have written about one size does not fit all. And the field is just developing so much, it's really hard to stay on top of it. But a lot of people are developing things that are very compatible or similar in what they're going after. And you mentioned another very important word, which is we've learned to titrate and we've learned to resource people so that they have the ability to manage their own emotion or their own self, and they can grow themselves if they're not in a state of hyperarousal or hypoarousal all the time. So those are first order of business matters before we can get into some of the other issues that are necessary to get into.
Do you think there's any personality style which suggests that trauma work could actually not be useful. I find that, you know, the person has to be ready to do the work. They have to do it safely.
Mhm.
You have to titrate it. All those good kinds of things you need. Each grounding containment, you need to use stage, all those obvious things that you point out in your books. But I've also noticed that there's certain personality styles which I think are probably contraindicated for trauma work. As an example, I think somebody who has Munchausen's by proxy
Mhm.
would not be a good candidate for doing trauma work. Have you noticed that?
Yes, with one patient. Um, but you know this better than I do because you've worked with offenders much more. But I think the highly narcissistic person to the point of being a traumatic narcissist towards others, and not seeing that he or she as a narcissist, as that type of narcissist, is destructive. I think that that's probably not a good candidate, or somebody who's sociopathic is not necessarily going to be a good candidate for psychotherapy.
I had a client, and I want to use this as an example, who had been seeing a therapist for 10 years, and she said that she gestalted her father to death and was very affectively attuned.
Mhm.
And she wanted to do trauma work, and she wanted to do more trauma work, and could she do 3 trauma sessions a week? And it was sort of like she was addicted to doing trauma work.
Mhm.
And it felt to me like it would be wrong to do trauma work with that person because she was using the trauma work to avoid doing trauma work.
Mhm. Mhm. Yeah. Yep. Yeah.
What would
There are
you approach
many.
that?
Yeah, there are many of those kinds of paradoxes for sure. You know, that some colleagues from our center wrote a lovely book this year. This is about all the paradoxes, and John Breer, of course, has written about the pain paradox. So that's another thing that we need to be prepared for, that some of these clients do get over invested and over involved in doing work that's going to keep them away from doing the work, from really getting there. Um,
So there's a
and
difference between acting as if you're feeling and feeling.
right, right.
And you can sense it as a therapist, but it's never really clear how to get under it.
Right, right. But you know, the books by David Wallen is another book working with attachment issues. And also, I don't know if you've seen the recent book by Muller from Canada, which is talking about the difficulty opening up, is the title of the book. It's a Norton book. It's Robert Muller. And he wrote the book Working with the Avoidant Client. And all 3 of these books really talk about how the therapist can begin to get under the defense that the client in each attachment style puts up. And I found them, you know, again, it's not an answer for everything, but I found those 3 books very useful in terms of when you get that feel, or somebody is you know, provoking you with their attachment style, like the avoidant client who, you know, tells you you have nothing to give to them, and you know that they're contemptuous towards psychotherapy. At the same time, they're absolutely desperate for help. You know, learning to begin to approach them and present their style back to them, and how it's not working for them, but also how it's something that they developed very understandably from an environment that didn't meet their needs. You know, those kind of books I've found really helpful as well in just getting some more techniques under my belt to approach those issues.
Thank you. You know, if I had to identify maybe the greatest stress for me, and my suspicion for you too, along the way, has been the insurance companies. And I'll get on the phone with an insurance company and I'll say this person finally feels safe enough to deal with their rate for the first time after 10 years of outpatient psychotherapy. And we've started working with this and this, and her OCD symptoms and her depression and anxiety are about to remit. and the insurance company will then say that they do not want to pay because they feel like the trauma work will make the patient worse, not better.
Right.
You know, it feels so re-victimizing and enraging because you know that you're doing the work and they get better. I don't know. Has there been any progress in getting to the field of psychiatry on this?
I don't know, Mark. You know, I'm not in practice anymore, and I haven't been for the last 5 years, so I haven't had to deal with that. But you know, I don't think it's changed very much from what I'm hearing from colleagues, and you know, the COVID time period hasn't helped with that. Well, maybe it has helped. It's opened up some psychotherapy and different modes of psychotherapy, but no, I think there's a total misunderstanding. And in our treatment program, we immediately switched the language that we were using, playing the game of the insurance companies, which was we're working on stabilizing the client and giving them skills. You know, at the same time, we were also working with the trauma. But if you say working with the trauma, they take it as meaning you're going to make the client far worse instead of better. But I also wanted to comment, yes, that's been a thorn in everybody's side, managed care and mismanaged care, and you know, the whole financial thing and the stress that puts the therapist under. But I wanted to make another note, and I know you've experienced this too, is that the greatest stress in my career, ironically, has been other colleagues who have been in a mode of betraying their colleagues or betraying their clients. And I wrote an article about this called Colleague Betrayal. And because of the closeness and because I anticipated, and I approached the world by assuming people are going to be healthy and are going to be care for me, or are going to be careful about my welfare as I am with them. And that didn't hold true. And that's been the most difficult thing of my career. Along with the false memory movement. That's another sub-issue of colleagues also, or other professionals being very assaultive and negative of our work.
Yeah, well, I certainly agree with you on that, but I don't have anything intelligent to say about that other than the fact that you just have to stay in your office and do your work.
Right, right.
Okay.
Well, sometimes you have to get out of your office, you know, and that's where we've differed too. I've taken a bit more public stance than you have with the work that I've done with APA, and trying to work at a more system level to try to get some of these educational things out there and some of these other issues.
Thank God. Yeah. You're my hero.
Thank you.
So I want to get back to some of the core issues, which is how to work with memory. I still think that there's a bit of confusion in that area. Like, for example, if you read one of the solution-focused therapy books, I can read you a sentence out of it where it says, do not work with a person's memory of trauma. And I worry about that, because if any time a client wants to come in and say something bad happened to me and I need to tell you, and you say, please don't tell me, it feels like it has the potential for re-victimization. And yet, you know, I understand where they're coming from, which is that the person can get lost in the past, and it's really important to talk about the past influence on the present. So what are your thoughts about that?
Well, I think to wholesale shut down like that is destructive rather than constructive. And if somebody comes in and says, I have something traumatic to talk about, that is up to us to create a circumstance that's safe enough for them to do so, and to help with that, but to also help modulate it. You know, if somebody is what you were talking about before, if somebody is steeped in their memory and they can't get out of it, that's not healthy. And we have to help them to learn to deal with that. And this emotional regulation, titration, resourcing, all of those are very important. And teaching that to clients. If somebody wants to tell me, right at the start of therapy, their whole story and all the emotions, and they end up decompensated in a hospital, I mean, that's not a way to go. And so I talk to clients very early on from the start of treatment that we're not going to, I do want to hear the story, and it's important to hear the story, but it's also important to maintain their ability to function in the world. And we can do it gradually and not something that has to be done all in one piece in a way that's overwhelming. So I like the term graduated or gradual uncovering of the trauma. I usually early on want to know something about the circumstances of the trauma, the who, what, where. But then I ask clients to put aside the feelings for a while as we do some other work. And then when memory processing starts, then we want to put the feelings and the memories together to begin to be able to process some of what has been split off and left aside in the interest of, being able to survive or adapt to it.
Well, I agree with everything you said, but I think there's a cultural bias here where, I used to call it the Marine philosophy, just get on with your life, move on. We've all had
Oh, sure.
And I think it influences therapy and therapists sometimes with the idea that if you go back and revisit aspects of the past, you're going to get worse. And I think it's wrong. I think that what psychotherapy needs to be is, by very definition, that you begin to integrate your past, present, and future, and that if the cost of not looking at one's past leaves you open to reenactment, repetition, and self-injury.
Yeah, yeah. I totally agree with that. I learned a lot when I did my dissertation, and then I did a subsequent piece of research. And in my dissertation, I asked at the time women, and then my second one, women and men who had had incest experience, to volunteer to talk to me in detail about their experiences. And I developed a multi-page questionnaire that I asked all of them. And I asked the questions very calmly. They were questions that were very factual. They were, tell me about this, tell me about that. So it wasn't directive at all. It was asking people to also assess how they thought they were affected positively or negatively. So it was neutral. And you know what? At the end of 60 interviews, every one of those people I interviewed, when I asked them how the interview was for them, they said, you asked the right questions and you asked them in a way that I could answer. And it hurt, but it feels better to know that somebody heard this and somebody was responsive and let me just tell my story. So this has to do also with the dimension that's highly traumatizing, which is that child sexual abuse is hidden. It's not talked about, even today. And so people grow up with these horrible experiences and memories that there's no place to go with them. And I think it really speaks to how we listen and how we allow ourselves to listen. And I asked at the end of those interviews, I also indicated that I was available if anybody had adverse reactions to having talked to me about their experience. I never heard from one of them. So I can only assume that it was a helpful kind of thing. Now, it wasn't psychotherapy, it was a research thing, but it also was taking horrible memories and asking people to talk about them and to put them in some kind of order.
So I think that's sort of one component of effective, good therapy here. I think as we visit it, there's two other components that seem to be worthy of mention. And it came, I think, as Pat Riesick did her work on cognitive reprocessing therapy, which is that there are stuck points that people get into. And I think it's revisiting Mardi Horwitz here, because what Mardi Horwitz said is, basically good trauma work is grief work. And people get stuck in their grief with something. And the key aspect is finding out where they're stuck and how to get them unstuck.
Right.
And so Patty did this beautiful work where, she had college students just interview people, much like you were talking about, and they would tell their story. And then she had them focus on their stuck points and developed this empirical work for breaking through people's stuck points. And I still find that cognitive-based therapies are really necessary. And so as the person is talking about their trauma, the EMDR, IFS, other modalities are really particularly good at helping people identify where they got stuck in the trauma and finding really creative ways of beginning to break through those stuck points.
Right.
So that to me is part of the art, is finding out where the stuckness is and helping them get unstuck in that process. And I think that I've been seeing a lot of Afghanistan and Iraq vets recently because I have a contract with TRICARE. And it's been some of the most rewarding work I've ever done, because they'll come in after, let's say, killing 20 people and have all that PTSD piece. And they're doing pretty good work in the VA around that, but they aren't getting better because the complex trauma that's underneath it is not yet being touched. And so, now what I'm having to do is, integrate the two of them together. And I think we don't yet have a satisfactory model for the VA of how to, what is an optimal model for, these soldiers returning from Afghanistan and Iraq, which integrates both complex trauma and PTSD trauma.
Yeah. Well, Mark, it's not only those two war arenas. Vietnam veterans are now, there seems to be a new cycle going on of vets who are in their 70s who are becoming symptomatic when maybe they haven't been, or the symptoms are just emerging with age and age-related challenges, et cetera. And also the research that has come out of Vietnam and the Vietnam readjustment studies show that a substantial proportion of individuals who never really did get better, in fact, have a history of complex trauma, which is not touched by the trauma-focused therapies that the VA has endorsed. So I totally agree with you that another treatment model, and Marilyn Cloitra's model of the STARE program, which is to look at the trauma, but also to look at affect regulation and other issues. My understanding is now it's being adapted, and at least it's being used in Europe at this point, but I think it's being called STARE Enhanced. That is something that is, trying to work at both levels. And I think we're going to see that's another cutting edge of the field that we're on and that we're going to keep seeing.
Right. Yeah. She does narrative therapy too. That's really quite elegant.
Right.
Yeah, very nice.
Yep.
So, yeah, I agree. And I think that so the second component is the cognitive reprocessing that goes into it. And then I think that the other thing that really needs some attention is that as the person is doing this work, that third component of grieving, I mean, you talk about it nicely in your book, but what I noticed was, as I looked at our clients and I tried to understand which ones got better and which ones didn't, one of the things that happened was that as a result of therapy, they would get sadder. And it was sadness, but not depression. Depression was neurovegetative and really hurt them. But there was an appreciation that by beginning to talk about the past and the things that happened to them, the natural result of that was that they were going to get sad. And so we would educate them that that part of this process is mourning and grief work. And you talk about that nicely in your books. And but I'm not sure that that's been spelled out as clearly as it needs to be, that there is a stage of therapy before you even go to meaning making, which is a year-long process of grieving some of the losses in their life and what that consists of.
Right, right. And I think that overlaps a lot with coming to terms with the betrayal, and coming to terms with the cost of the betrayal, which does lead to a lot of grief and a lot of mourning, as well as a lot of anger. I just reviewed a book this week called Leaving the Darkness Behind, that is written by a psychologist friend, that will be published this year. And it's a book about her own experiences, but also she pulls the psychological literature together about a lot of these issues in a very user-friendly way. And she talks a lot about the grief. She's a meaning-making grief specialist, and she's incorporating a lot of that into her particular book. So we're going to see more of that, I think.
When complex trauma began to be given attention by the American Psychiatric Association, and more books began to appear in complex trauma, how did that change the field?
Well, I think the American Psychiatric Association has not accepted complex trauma except as an associated feature of PTSD. And you know the history, that it was proposed for the DSM-4. We're now at DSM-5, and it's still not listed as a full diagnosis. So, many of us feel that that's been a failure, and that has been legitimized in the ICD, the International Classification of Disorders, instead. So I'm waiting for the APA, American Psychiatric, to catch up. But I think the fact that we now have a diagnosis makes an enormous difference in terms of legitimizing the issue, legitimizing the reactions, getting research money. Hopefully we'll have better research, and many of us as clinicians don't have research labs to be able to do these studies. And, research labs have not been able to get money for complex PTSD and its treatment because it's multi-component and because it's complex and expensive and takes a long time. So I think we'll see changes in that. And in fact, that is changing at the moment. There are labs in Europe in particular who have begun to study treatments for PTSD in a more systematic way.
Well, what I've tried to do over the years, and so some colleagues do this and some don't, is when someone comes in, I typically will ask permission to talk to their mother, their father, their brother, their sister, their next door neighbor, their spouse. In a systemic way, I want to try to get to know them through other people's eyes, and to get to understand the system. And each of them helped me kind of get a component of the whole big gestalt, big picture of what's going on. And then if I can bring those people in without them feeling like I'm blaming them, but that I really want to help the person heal, I can bring them in as part of the process. And oftentimes I can sit down and bring the mother in or the father in, do a couple individual sessions with them, develop enough rapport that I can get them to begin to talk in great depth about the things that influenced and hurt them and injured them along the way. The goal of this is not really forgiveness, but much more for people to begin to understand, what happened, why it happened, how it happened, and how it affected them. And the ultimate goal being reconnection. I remember when I was first dealing with incest, like you, that what the kids would say is, I just want my family. I want my mom. I want to have a mom. I want to have a family. And so much of what the system was doing was orienting them to lose their family. And so the very best thing I could do for the incest survivor child was to rehabilitate the mother so that she was a good enough mother and the child could have adequate parenting. And in a very similar kind of way, as we're repairing these systems, the goal to me is if we can begin to get enough change in the family of origin, that there can be some reconnection, so that I don't, I call it acceptance more than forgiveness, but you can begin to accept what happened, understand why it happened, and it no longer plagues you with hatred and anger and rage.
And it's no longer all your fault, or because you did something or didn't do something. I mean, I think that's been another thing that attachment research has helped us to understand, is the intergenerational dynamics that go on, and that often parents have their own histories of trauma and unresolved loss that plays out with their own parenting with their children. So yes, if we can do something at that generation, that's great. If we can help our clients to heal so that they don't pass it down in the next generation, that's great as well. And these days, there's a lot more attention to the intergenerational transmission. And also now that's expanding to also looking at historical trauma, and what's happened with whole cultures, or groups that have passed down these dynamics from generation to generation.
One of the people you mentioned,
Go ahead.
One of the people you mentioned along the way that influenced both of us was Joan Turkis, and I don't think people know her as well. But what I used to hear her lecture, and the thing that she touched me more than anything else was pacing. And I thought that has been under talked about, because pacing in this therapy is so vital, and getting enough momentum to be able, particularly when you have the insurance company on your back. And Joan used to say that a person needs to process a memory, about 8 times, she would say. And she would talk about how that was. What is your thought about pacing?
I go with Joan's term, which is make haste slowly. And yes, we need to pace. There are times when we really need to promote clients to pick up the pace, because many of these clients are highly avoidant, as you know. And there are other times when we have to ask them to slow things down so that they can notice things and that they can process things appropriately. And noticing and being mindful is the very opposite of dissociation, bringing the dissociatives back into this. And so, with our dissociative clients, they're prone to be low energy and they use that defense really well. But we have to encourage them to start to face things and to begin to use other ways of coping with things that are uncomfortable or emotions they don't want to feel. So yes, I think pacing is very important. It's very individualized with the client. I also wanted to mention, Mark, I think another thing that has come into the field that's from the past and has been renewed recently is the focus on, obviously on the body, but experiential focus, and also engaging the client in mutual problem solving after something is noticed. So the work of Janina Fisher, Pat Ogden, Peter Levine on noticing physiological changes to get into more noticing what one's emotions are and being with them in the moment. And I don't know about you, but my training was more psychodynamic and cognitive and interpretive. And so learning to be experiential in my approach has been like putting everything backwards. And it takes time to do that, but it's really putting the clients, it's a mentalizing kind of exercise. It's putting the client back into themselves and encouraging them to feel things that they normally wouldn't feel, to know about things they normally wouldn't know about, to problem solve when, for example, a relapse occurs, to not just treat it as a relapse, but as a problem to be solved and something that maybe we can work on together, or maybe they have an idea about how they can do it better. So I think that's a whole other line of approach that many
it brings us back to where we started.
This
This brings us back to where we started, because you and I had dinner recently, and I asked you over dinner, what is your thinking about catharsis? And because Mardi Horwitz put a lot of emphasis on catharsis, and
That was a good dinner conversation, right? A good dinner topic.
Dick
People
Schwartz,
know.
Dick Schwartz talks about unburdening, and we always feel, Lori and I anyway, that Dick's model is so helpful to us because what we do is by beginning to talk about trauma, we increase the toxicity. And so the body holds all that. And so there needs to be some release of that in some ways. And so, a lot of the expressive therapy modes are in releasing some of the toxicity of dealing with the trauma. And Mardi Horwitz called that catharsis at the time. And then the field left that behind. Maybe Jean Briere didn't, but a lot of the field did. And I think a lot of these somatic-based therapies are saying that somehow one has to unburden, because otherwise doing all the work can actually be contributing to acting out. So a person could come in, do a piece of trauma work, leave the session and go drink in a destructive way or cut on themselves. That would be incredibly damaging. But if you do the proper unburdening, you find that doesn't occur. What's your theory? What is your feeling about catharsis?
Well, I agree with that. And also the idea of doing it in the context of a relationship where someone is paying attention to you and responding to you and not ignoring it and basically accepting it as you're doing that or encouraging you to do that. That's what I see as catharsis is you're saying, putting it out there, however it gets put out, but also the significance of a responsive other person who's there to support it, not to suppress it, and to allow it. It can be enormously relieving.
It's just that sometimes we get too cognitive, and we have to remember that the goal is integrating a cognitive affective experience, which is oriented towards the development of the self.
Right.
And that affect is the golden door into the work with trauma.
Yeah.
So, we should mention Diana Fosha and her beautiful work on built on Davinlou's work on affect.
Right. Well, that's one of the things that, as I look back at my career, that I'm most embarrassed about, because I'm so, and you're this way too, I'm so intellectual and cognitively oriented. And some of my early patients, I'm sure I just lectured at them and let them know what was in books. Well, that's not particularly helpful. I mean, yes, education, psychoeducation is useful and is recommended, but if you're only doing that kind of cognitive distanced work or intellectualized work, you're not doing the work and you're not getting to the affect and you're not getting to the experience, which I think we've come to learn is essential. And listening to Janina Fisher, she's been really funny in saying that I think we had similar training, and she said it took her 10 years to begin to understand how to work somatically rather than cognitively, and to work with the body and to go from that level. And I found it very difficult to make that transfer. Even as I understand it, it's a whole new skill set.
Yeah, I agree with you. It's certainly my deficit too. I'm glad I have Lori as a co-therapist, because she does psychodrama and expressive work. And so, I get them up in their heads and then she gets them out of their heads.
Yep. Yeah, that's a really good pairing. Man, we've covered a lot of territory. Should we open up to questions?
Yeah, let's ask questions. Go to the chat room.
You guys have 2 questions in the Q&A box right there.
Okay.
It says, I'll be putting together resources list for everyone. That's you.
Okay.
Suzanne, can you read the question?
Yeah, the first one is, as a newer clinician in the field, becoming a trauma specialist can seem overwhelming. With all the modalities available to treat trauma, where should a clinician start in order to become a trauma specialist?
I would say if you haven't gotten any exposure in your professional training, that you should seek out You know, there are now through various organizations courses where you can get certified in doing trauma treatment. For example, the Trauma Research Foundation in Boston, and there are additional programs across the country now. So you'd have to Google that and go looking for it. I also would highly recommend John Brier's book with Catherine Scott, which is Guidelines for Doing Psychotherapy with Trauma. It's a good overview. And if I do say so myself, my book with Julian Ford, which we co-authored on treating complex trauma, gives, I call it the therapist companion, because it helps, that's the one, it helps individuals to know what some of the issues are that you're going to face as you go along. Also, there's an article that came out in 1988 by James Chu on treatment traps, 10 treatment traps in the treatment of trauma, which was my Bible for a while, of things to really watch out for as you start to do this treatment. So those are some general ways also to make sure that you have consultation and or supervision as you go along, whether a consultation group or a person that you consult with. And also, yes, we covered a lot of things here, but you don't have to know all of them. Do it gradually and build your confidence as you go along. I do recommend finding one or two treatment models that appeal to you and getting specialized treatment and certification, which is ever more available. Mark,
when people come work here, I give them 3 books to start out with, and have them read them cover to cover. One is Christine's book, which I've always loved. The second one is Janina's book, Healing Trauma. I love this book. And the third one is Kathy Steele and Vander Hart and Boone's book on dissociation. That's so well written. I mean, I just, it's almost breathtaking how really well written it is and instructive to the clinician. So those are the 3 that I have them start out with. And then I usually have them do the certification in EMDR now, because the new EMDR work really integrates all the modalities. And then hang around Dick Schwartz a little bit because he's a genius.
So you have another question here. Do you think it is necessary for the patient to tell all the details of their trauma?
My response to that is sometimes yes. Not always, because that can be a never-ending situation, but as Mark was saying, that there are often hot spots or high points or things, what I call secondary secrets, that until they come out, they can get in the way of healing. And an example would be someone who keeps the secret that they had a sexual response during sexual abuse, or that they sought out their abuser for sexual contact because that was the only time they felt like they could make contact. Those are really, really shameful secrets that once they come out and once they're accepted, they can be very profound to a person's healing. So it really varies by the situation.
I would add to that Francine Shapira, who formulated EMDR, I did training with her many years ago. And what she talked about was that there are channels of trauma, and you would do one channel and you would, like a sponge, you would wring it out, and the person would get better, but still have problems. And because what would happen is that the first channel would leak into the second channel, and that would then leak into the third channel, and you had to clean out channels. And I love that formulation, because in the early days, we would do this really intense work around, let's say, the incest, and the person would get better a little bit, but there wouldn't be a full recovery, and you'd wonder, what do I need to do? And the realization was that the first piece of work isn't going to get resolved until you do the second piece of work, which then goes into the third piece of work. And so usually underneath each piece of work is another piece of work. And so the question is, do you have to do everything? And, you know, there's 365 days in a year and childhood goes on forever. So the answer is obviously not. So the question is, how much work do you need to do for the person to recover? And the answer to that is the client will tell you. In other words, if you follow the symptoms, they're kind of a barometer. And you may, like, for example, eating disorder, you have an anorexic who's not eating and they're dying. You do enough work and the anorexia subsides, the person begins to eat and you're refeeding them. And you think, oh God, that's successful treatment. Well, a year later, they may come back and they're still having eating problems. And that's a sign that probably there's something underneath that. As you clean out the next channel, they get better. So the ultimate goal to me is not recovery from the eating disorder. It's helping the person create a life worth living, to use Marshall Linehan's concept. And so it's a much broader kind of idea, which is your really goal in treatment is not removal of the symptom, but in helping the person create enough life that they can experience joy and happiness and love and relationship.
And Mark, let me chain on to that, because I think you're saying something else here too, is that sometimes our clients get better in the context of their treatment program, but then they have to go back out in the world. And if they're going back out to the situation that is the one that they left, that is extremely unhealthy or pathological, that may be the reason that they come back in with an eating disorder again. And the symptom is because there's still lots of stuff that might be going on within a family or within a context of a relationship, domestic violence or otherwise, that is extremely unhealthy, and the symptom is expressing itself again the way the individual learned to express it. So when you have somebody who's relapsing and coming back in, it really does, you know, as Mark is suggesting, it really does mean that you need to ask, and you really need to assess what else might be going on that might be leading to that kind of relapse.
You guys want to take a couple more questions?
Yep.
One more, because we're running out of time.
What are some of the differing trajectories that distinguish your work from one another? This was referenced by Christine, just generally speaking.
I don't know. I think I've mostly been influenced by internal family systems, because Dick Schwartz worked with us for a year. And, you know, so I use both internal family systems and EMDR with each of my clients. And that's the structure of what I do. And I'm very much interested in reenactment and repetition and trying to be able to see the symptom in that context.
Yeah, I think we've had very interesting, I think we do a lot of the same things, but we come from different directions. And over the years, we've had very interesting intersections, but our backgrounds would also, I think, assume that we would go after things, maybe the same things, but from a different perspective. Mark started out as a, you know, sex therapist, so those issues have been on his horizon, and also a family therapist and a couples therapist. So it makes sense that internal family work and couples work would be maybe more pronounced in the work that you do, Mark.
Great.
You know, and like I said, I started out psychodynamically and very interpretive, and have changed over time. Were I to go back into practice, I think I would pay much more attention to somatosensory work and really boning up my experience in affective work and experiential work.
Okay, well, Christine, it's been wonderful, and
Great
I love
to talk to you too.
And we have to do this more often.
Yep, I know. I learned a lot doing this. I love going over all of this. And the things that we've learned over the years and the things that have really stuck with us.
Yeah, 50 years is a long time. And
sure is.
It seems like it's gone by in a minute.
It has. It has.
Suzanne, thank you for setting this up. And thank you all for attending. And feel free to get in touch with us if you have further questions or to email us, and we're both very open to sharing.
Yes, absolutely. Thank you.
Have a great day.
Bye now.